just going through a little bit of a slideshow to share with you some information that to me as a nutritionist, and I served on the 2015 Dietary Guidelines for Americans, is sort of the impetus for why I think it's really important to help train you all as the next generation of healthcare professionals. And then what we're going to do is we're going to have our panelists come up and we're going to ask them a couple of questions, and then we're going to open the floor so that you can ask them some questions as well, okay? And Paul and I are going to tag team. We've been teaching now for a few years. Probably would have been longer, except that I was over at UNC, so that's okay. So one of the things that we wanted to share with you is some results from a national survey. This survey is done by the International Food Information Council. It has been done for the last 13 years. It's a national survey. They do a telephone interview of over 1,000 individuals in the United States. And they basically ask them questions about food and health. And so this question was more of like, okay, so what type of diets are you following right now? And so you can see the answers. That 10% of people are doing intermittent fasting. How many of you are familiar with intermittent fasting as a form of diet? Okay, I can see many hands up. 7% paleo, 4% low carb, 5% whole foods, 4% high protein, and 3% ketogenic high fat diets. A lot of these things are fad diets that keep coming in and out of the literature. And so when you're out there practicing, you're going to be hearing about some questions related to these fad diets. So I think it's really important to understand what's there. Thank you. But it's really funny that when we tell consumers we really want you to eat healthy, that the majority of consumers, A, don't know how to achieve a healthy diet. And that's because 80% of them, and these are the results from the 2018, say there's a lot of conflicting information about what foods to eat or avoid as part of a healthy diet. And then 59% said that this conflicting information that comes from so many different sources actually makes people doubt what they should be eating and our food supply system, okay?
Can you get that on that?
Yep.
Yeah.
I just wanted to jump in because I was telling Anna Maria earlier today. I think that this slide is really the heart of why we are here, right? Anybody who lives in the United States for 5 minutes understands that we are a country obsessed with food, right? We're eating it. When we're not eating it, we're talking about it, we're reading about it, we're watching it on TV, right? Food messages are everywhere, right? And what we also know is that information overload leads to confusion, leads to a challenge when it comes to disentangling good, valid, useful information from information that is none of those things, right? And it turns out there's more of the latter than the former. So who's going to help us figure out what information we should pay attention to, what messages we should attend to? You, right? That's why we're here, that's why you are here, because when it comes to curating this massive information overload, when it comes to translating all of these myriad messages into usable guidelines and advice, that's your job. And this speaks to how critical that job is.
Good point. I think he should have been on the dietary guidelines. Okay, so this next slide is about the different kinds of food values and labels that people are looking for. And so in fact, it basically says that people are looking for organic, the label organic, and they're looking for it in both foods and beverages, so about a quarter report that. They're also looking for the label of natural. So the American public really is interested in natural foods, and you can see that's even higher than organic. Clearly, there's been a big push lately, and rightfully so, given what's happening globally related to climate change, is the majority of the population is interested in food production when it comes to sustainable practices for our food production. Then there's some other things about pesticides. Less pesticides, there's definitely a drive for less pesticides. an affordable food supply. It seemed to be pretty relevant, and we're going to share this report with you with the post-survey that we're going to implement. People are willing to pay a little bit more for their food if they know it's grown sustainably, it is more natural, and it's a better quality product, right? Which is wonderful, with the exception of the fact that there is a subpopulation where they can't afford those kinds of foods. So it's part of our jobs too, being in this field, is how do we get healthy, affordable, organic, natural, good food to those individuals who can't afford it.
Okay, but let me add one more quick problem or challenge here, and that is, if you say organic, right, I know what that means if I read about the U.S. Department of Agriculture guidelines or requirements for that label. But if you say natural, you know what natural means? Nothing, exactly. It means nothing other than some idea of goodness, right, in terms of a specific way. And so that's part of your charge, is to help people negotiate that. Sustainable? Sure, that sounds good. Sustainable sounds great, but what does that mean? It actually does mean some very specific things in particular contexts, but in the aggregate, in some vague sense, again, part of your job, but also part of our jobs, is to help people make sense of that and help make that something that means something real. Let's move forward. And what we want to do is go from this national survey to a UVA survey. We conducted a survey last fall of all University of Virginia undergraduates, and we asked them about a number of different criteria for choosing particular foods to eat both in and out of the UVA dining halls. And not particularly surprising, the biggest, the most important, or the most highly rated criterion was taste. It tastes good. 94% chose that as either extremely or very important. Only 73% of UVA undergraduates chose healthy. 84% chose affordable. And then we got into some more specific criteria. I'm not going to go through all of these except to say that the percentage of UVA students who felt that these criteria were very or extremely important was much lower. 47% of UVA students said that it was very or extremely important that they choose food that was humanely raised. We assume they were talking about meat and poultry and fish here, not other things like vegetables. Sustainably produced, again, very vague, but 40% endorsed that. Fair trade and fair pay for workers, 44% endorsed that. Only 6% said that gluten-free food was an important or a very important or extremely important criterion. It turns out that's a really vocal 6%, and it's a vocal 6% that you all will hear from, and that UVA Dining hears from as well. 30% said organic, 22% non-GMO. We weren't asking them what they thought these terms mean. We simply wanted to get a sense of the sorts of criteria that people at UVA, students at UVA, are relying on. And again, as you can see, all of this, these bars are either half large or half small, depending on what your expectations were. I gotta tell you, I had no expectation whatsoever that anywhere near 22%, almost a quarter of UVA students would say that a low nitrogen footprint was extremely or very important, and yet that's what we found. We can talk more about this. We're actually writing up some of these results, and we can share them with you. Our guiding principle here is that if we want to change people's behaviors, people's perceptions, people's knowledge about food, we got to figure out what the baseline is.
So then we asked you all to fill out a survey before tonight. And so these are some of the results that you gave us. So do you trust your food system? Well, I would say that the majority of you moderately do not trust, okay? Neutral, moderately trust, only a small group actually trusts their food system.
Oh, sorry, I was fascinated.
Yeah. Please rate your understanding of the following topics. This is the reason why we're here. The red bar is sustainability in agriculture. You can see very knowledgeable, very few people selected that, whereas the majority of people said somewhat knowledgeable. Food grown using GMO technology, that's kind of like the purple bar. Once again, it fits really more, there's very few people with her feeling comfortable with that, and there's more in the somewhat knowledgeable, not very knowledgeable. So it's very clear in the answers to this survey that in fact, you also do not know very much about these topics, which is exactly why we're having this event, to actually sort of intrigue you to learn a little bit more, and hopefully we will shed some light. This was a question of how comfortable are you in answering consumers' questions about pesticides used. You can see that the majority were not very comfortable doing that. Next one. How comfortable are you in answering consumers' questions about foods and ingredients developed using biotechnology or GMO? Once again, you can see that that's the reason why we're here, not very comfortable, okay? Next one. Oh, where do you get information regarding farming and agricultural practices? So this is the one that I am most concerned about. So the majority of individuals say newspapers and lay journals. Scientific journals are also, pretty high up there, which is great, but the media and the food industry has done a very good job to confuse us in a lot of these different informations. And so it's very important that you get your information on these topics from credible sources, or else you too will not be representing clear messages to the broader American public.
And by the way, what's with professors? Right? We're down there with lay journals, for goodness sake.
So now we're back to the IFIC survey, all right? And this is where consumers put their trust in health professionals. They put their trust in you, okay? We have a group here of doctors, training future doctors, medical students, nursing students, and dietetic interns. It ends up that conversations with registered dietitian or nutritionist, they're the #1 group that the public actually wants to believe in, which makes a lot of sense because as nutritionists and dietitians, we are trained, but sometimes we're not as well trained in food production and agricultural systems processes. So we too need to make sure that we're up on top of that, okay? And then lastly, while 54% get information from a personal healthcare professional, look at that small percentage who say that, and this information actually resulted in a significant change. It's very, very low, okay? Which means, A, they don't value the information, we're not giving them enough information, or in fact, there needs to be more follow-up with our patients in order to make sure that they can act upon sort of the information that you're giving them in order to help prevent a disease or live with a certain disease that they might be diagnosed with, okay? So that's our last slide. We now want to call our panelists to come up so that we can actually start the discussion phase of tonight's program.
I teach pediatrics and community health nursing. I grew up on a farm not far from here. And so I guess I have a little bit different perspective on things, having grown up on a farm. I don't have quite the romantic notions of farm because I know how much work a farm is. But I do value the food that we get from our farms. And I also I have students in community health out in Louisa. And I have 2 students, I place 2 students, it's kind of I started a couple years ago placing 2 students at a food bank out there. And so they're there to take blood pressures, blood sugars, and to talk to people about health and about nutrition and about eating and using the foods there. Now we actually happen to have a really great food bank in Louisa. Or maybe I should say this later. We have a great food bank, so we have lots of fresh fruits and vegetables, so they get to talk about a lot of different things.
Sybil?
I'm Sybil Krams. I'm associate professor in kinesiology. I'm a registered dietitian, and I work with children. especially focusing on how to improve their diet quality. I don't know if some of you know that dietary intake patterns are established very early in life and they tend to track throughout the life cycle. So I think it's very important to let caretakers of children know how important it is to teach healthy nutrition early.
Evelyn?
I'm Evelyn Scott, Assistant Professor in General Internal Medicine, and I spend most of my days at University Medical Associates, which is the largest outpatient clinic for adults at UVA, with a population that is predominantly underserved, a lot of poverty level, financially screened patients.
I'm Catherine Bassbaum. I'm a clinical dietitian at the Heart and Vascular Center. I treat adult patients in the inpatient side and the outpatient side. So I see a lot of patients, a lot of them low income or not having a lot of resources, and I'm helping them with coronary artery disease, heart failure, overweight, underweight, diabetes, and some kidney disease as well.
Max?
I'm Max Luna. I'm an associate professor of medicine in the division of cardiology. 70% of my time is taking care of patients, training future cardiologists, introducing the concept of prevention into cardiovascular education. And the rest of my time I dedicate in health disparities and minority health. We have a Latino health initiative where we introduce a lot of these topics of healthy food, food security, and we examine the social determinants of the access of food security, of healthy foods. That is practically one of the reasons why people don't follow advice, is because our advice is the beginning of changing habits. And the next is there are 6 or 7 different reasons why people choose their foods, and it's access to food, paying for food, time to buy, time to prepare, food, the availability, seasonal, yearly around, cultural, taste. There's many things that determine why people don't follow advice. But more importantly, and you were just talking about the loss of trust in institutions has begun with the loss of trust in medicine. When we spend 5 or 10 minutes with a patient and we don't spend any time addressing their risk factors for prevention. So unfortunately, you all may know that 22 years ago, Americans began looking for primary care outside of the conventional medical care. It's alternative medicine, which is valuable, tremendously complementary to what we do, but they have lost trust. So that's why we need to reset our priorities and see if we want to make a difference in our families or patients' lives by spending time talking about how to prevent disease, how to identify why they're not able to follow our advice. And it's basically not in the clinical setting, it's in the societal setting that they are the biggest barriers of changing lifestyle and lifestyle modification, dietary changes.
So I'm going to start just by asking a couple of questions, and then, Paul, please jump in, and then we'll open it up. So one of the questions that I got even like last week when I was doing some consulting, and I would be interested in knowing your answers, is what happens when a patient asks you if eating organic is healthier for them? What do you tell them?
I get that question a lot, although sometimes more so than that, I get patients that are assuming already that the organic is going to be have more nutritional value to it, and all I can tell them is what I've read in the research, which primarily shows that there generally is not a big difference in the nutrient density of organic versus conventional produce. There might be a difference in taste, and there's maybe other reasons, but if they're looking for more nutrition by buying organic, then I let them know that that's not the case.
Most of the people that I find we deal with can't afford every type of food that they might want to have. And what I think is more important to emphasize is eating more fresh fruits and vegetables, not necessarily organic. you know, if having to purchase something that's organic is going to make it more expensive, I'd rather them spend more money on just getting, or having lots of fresh fruits and vegetables than necessarily being organic. So that's what I try to emphasize if their dollars are limited, which many of our patients, that's true.
I would agree with that. I think nutritionally, I think they're probably equivalent. The difference being potentially exposure to pesticides, and the question is still out there: is that necessarily a bad thing? Is that a neutral thing? And you probably know that there's a list that comes out every year about the foods that are associated with the highest pesticide levels.
Dirty dozen.
Pardon me?
Dirty dozen.
The dirty dozen, that's right. If my patients are asking, like, is it really worth the cost, which most of mine don't, because they don't have that choice. And I would agree with you that more vegetables and fruit is good no matter. But if they ask, then I direct them to that. And so if they can afford organic strawberries, for example, then that might be a good thing.
So what about young mothers and starting their kids off? Do you hear a lot of young mothers asking that question in terms of organics?
Definitely. I agree with what's been said by my other fellow panelists here, but I want to add to that just asking the question and being curious about maximizing the exposure to more nutritious food, but also being aware that maybe there are foods out there that are not, storable on the countertop for unlimited times. Like, I bought strawberries, after 10 days they just look the same way than they did before. But can I still give them to my kids, like my little 2-year-old? I mean, those are interesting questions, and I think just asking about organic and knowing and being curious about organic is a proxy, is an indicator for people being curious about what's going on with our food supply, what is going on with the things that we're eating every day. And especially those who care for young children tend to be protective and they want to ensure a good start in life. So I think, again, it's a good population to start having that conversation with.
So if you had to pick like one media outlet or one resource that you tell your patients to go to, what is that resource, and why is it that you're selecting that particular resource for them to go to for information related to these types of topics?
So if I'm seeing a patient and I have 20 minutes and I've already addressed their hypertension and diabetes and referred them for a sleep study and done all the things that we normally do with our patients, and then I want to spend a little bit of time talking about what is an appropriate diet, and it's somebody who has a little bit of savvy and at least access to a computer, then one of my go-tos is the DASH diet. You're probably familiar with that. If you're not, lots of fruits and vegetables, low-fat dairy, and I do that because it is one of the most well-validated diets, and there's lots of information online. It's a great resource. If they just Google DASH diet, they'll come up with a lot of references, some recipes, the supporting data for it, and I find patients are able to understand that and like to have that reference.
Well, chime in. I think it's great if we could refer people to scientific literature and they would read it. In my experience, especially with busy parents, if I would want to reach a lot of people and make them believe it, it would have to be something commercial size on a Saturday morning when the kids are watching TV, something like that. So we need to kind of differentiate between the delivery method when people are actually paying attention and how long the message is and can they get the information from that medium. And again, I work predominantly with parents of young kids, and when you run after your 2-year-old, you're not likely to sit down and actually read and comprehend what you're reading. So in short little pieces.
Well, go ahead.
And yeah, the challenge, what we use, and we have two main sources: the American Heart Association, that has tremendous avenues in multiple languages to orient people on their 7S, which is the simple 6 risk factors, and the last one was just added, the modifiable risk factors. the last one was added is dietary changes. Although 4 of the 6 risk factors are related to diet, which is hypertension, diabetes, obesity, and actually those 3, they're added dietary changes as a strategy to narrow the gap of healthy eating. And then the other is our society has a smartheart.org, which is the patient-friendly information from our Society of American College of Cardiology. What is sometimes challenging is that science is not consistent in some ways, and I want to open the debate. Last week, there's a tremendous study, 130,000 people followed for the last 10 years in a very Salim Yusuf, a renowned researcher from McMaster, showing that eating more dairy products are beneficial to reduce risk of cardiovascular events. And then what we as physicians, because the day after, New York Times, the Time magazine has an article on that. The day after that, we got savvy patients saying, well, you stopped eating, you've been telling me to stop drinking for whole milk or my butter. And that what we need to do is look at the evidence, look at the design. This is a cohort study. They didn't intervene, control to placebo, control to another diet. So it's a moving target. Evidence is a moving target, and we need to scrutinize the evidence published in the best journal in the world. And I don't know if you're familiar with that, Ana Maria, the Lancet paper from 10 days ago that we have been reviewing, discussing to see how to respond to our patients. So even though we try to read the more systematic and recognized source of literature, it's a moving target. So then we have a patient losing trust, and okay, last year it was that we can eat our eggs. Now we can eat our milk. Well, now we can drink our full milk. I can give full butter to my husband. So it's a moving target. So we need to understand that the patients lose some trust. But the critical thing is establish as a future clinician, nutritionists, nurses, and physicians, establish that relationship with your patients so they trust you, and then you guide them into the change in evidence throughout their lifetime, that the relationship that you have with your patients. So it's a challenge. It's a challenge.
So, I would add to that, and this is my beef with the media, is that they like to take these individual studies and make it sound like that is the last and final piece of evidence, which in fact, what we should all be learning, I hope, during your training, is that you need to take each one of these studies and put them into the context of the total body of evidence that's out there and see how it contributes, or, perhaps provide a little way of looking at something in a slightly different angle.
Or hypothesis generating.
Exactly, or hypothesis generating is absolutely true, because that's one of the things that when, as a member of the Dietary Guidelines Committee, we had to actually look at all the different evidence that's out there on many of these different topics. And clearly, when we start looking at the evidence, we look at the hierarchy of scientific evidence, which is randomized clinical trials. And while they're not perfect, and we know they're not perfect because you wonder who participates in those trials, right? Still, they're the only thing that we can say with greater certainty that A caused B, okay? As opposed to some of these cross-sectional studies. And then the last, the one that goes right underneath the randomized trials are these long, well-done prospective cohort studies. But even then, we need to have them be large, they need to be from all across the globe in terms of providing some of this information. So that's the one thing, if you go away at all tonight with a piece of message, the one thing that I want you to realize is you will get questions about what study just came out yesterday and what NBC just covered. And you need to remind yourself that you should go and put that article back into the context of what other last systematic review was just published on it. Because that will help you then answer your patient's questions.
We just have,
Yeah,
I was just gonna say, and sometimes I think we have to be honest and say, we've found new research, or we've got new research that has changed our mind on some things. I mean, there are some things that we have changed, and I think you have to be honest with your patients. And I think developing a trust with them is the most important thing. You know, if you're trying to like pretend, well, we didn't tell you this last week, you know, that doesn't develop trust. I think if you develop trust, and you can say, things have changed a little, and we once thought this, but now we realize that this really is more important. And, you know, this is what we think is best now.
I just want to jump in and say, I think there are a couple of related disconnects. And the first disconnect is that between what the science says and what people hear, what the media report. But the second disconnect is between our state of knowledge and the cultural response, right? Because we tend not to know how to modulate, right? Or to react, like, oh, saturated fats are bad, you can never eat butter again, right? Or, oh, now I'm allowed to eat as much butter as possible, I'm going to do that, right? And so part, I think, of your job is negotiating, translating, curating the science, helping people navigate through these conflicting messages through the media, but also helping to come up with a reasonable response, right? If blueberries lower or raise marginally the probability of some rare event, that probably shouldn't mean you should only or never eat blueberries again, right? Am I right? Again, I'm a political scientist, but that seems like kind of uncommon common sense.
Absolutely.
Yeah, Catherine.
Yeah. Well, I just, I was nodding because I often get patients that, you know, they love to say, well, I can eat dark chocolate, right, because that's good for me. I just read that coffee is good for me. Or should I be drinking, you know, dark cherry juice because I just read that it'll help me run faster. Like there's all these studies out there that they're doing. A lot of them are animal studies. A lot of them are not conclusive, and they're giving their subjects, or, you know, human or otherwise, you know, high concentrations of these things that, so blueberries, for example. So when they come to me and say like, well, you know, I heard on Dr. Oz that I should eat more strawberries because it'll help with my cirrhosis, or, you know, something kind of out of the blue like that.
So strawberry daiquiris just cancel each other out.
Right. So what I remind them of is I say, look, if you're getting advice from a friend or a family member or your mother's sister's aunt, or you're seeing something on TV or the internet, just, you know, take it with a grain of salt, and know that these are from studies that are generally not seeing results from just eating a few every day of blank. And that if you can, take your, you know, ask your dietitian or ask your doctor, your healthcare practitioner, ask them about it before you go out and buy some supplement or some book or go on some diet or start eating, you know, blueberries. So.
Yes, we want to open up questions to you all. What kind of questions do you have for our panelists? And stand up so we can hear you. I know. Well, because it'll be hard, unless you want to talk really loud from where you're sitting.
Okay. Well,
Wait, and also say your name and where you're coming from.
What are you doing?
And your pet's name.
Two questions on the side. So I'm Kendra. I'm in University of Virginia School of Nursing. I'm in the CNL program with these folks. She's not a CNL, but she's a nurse. My question is for those of you that work particularly with like cardiovascular disease. What are your current recommendations to patients regarding diet in a preventative sense? And what are you encouraging your patients to do or to consume in regards to like meat and dairy, based on research that is currently out there on their effects on vascular health?
Well, you just talked about this mind-blowing study about the
We
full-fat dairy.
shouldn't talk
I'm
about
not-
it yet because.
Yeah, I don't think we should talk about it yet. I mean, I can say from my standpoint that if I have I'm asked to consult with a patient that is interested in preventing cardiac events or preventative measures, lifestyle measures, they don't want to go on the statin or they want to get off the blood pressure medication or whatever, then I want them to be eating an abundance of the foods that we know that research tells us are cardioprotective. So the fruits and vegetables, ideally I want to see 5 servings a day of produce. I want to see whole grains. I want to see lots of heart-healthy fats, the plant-based fats or from your fatty cold water fish. So these are the things, as far as the meats and the dairy and the processed food, ideally I want as little as possible. And the proteins, the animal proteins, I want to see lean. I haven't seen anything to say that that liberalizing the amount of saturated fat in the diet is A-okay yet. So I still want to see less than 10% of daily total calories from saturated fat and sugar as well, less than 10% from added sugars.
Yeah, I think you described it. So the data, when we look at these big drugs, statins, they give us a 3, 5, 10% absolute risk reduction, 30% relative risk reduction. When you compare the latest dietary trials in high or average risk cardiovascular disease, they have shown 50-60% event reduction, and that is going through the Mediterranean route, which is a LION study, randomized a low-fat diet, the American Heart Association low-fat diet, compared to the Mediterranean style, seeds, legumes.
Jeez, Max.
The study was canceled. So we can forget about that study. So that's the LION study. And then the Spain did a 6,000 people randomized study, Mediterranean diet, American Heart Association diet, and 2 arms of adding 30 cc's of olive oil, and 30 grams of nuts and vegetables, nuts and tree nuts. And that added dramatic event reduction. So a lot of seeds, which carries your PUFA, your polyunsaturated fatty acids, and oil, olive oil carries your monosaturated fatty acids, are reduction in events through cholesterol and through other means, and as an antioxidant as well. So Mediterranean diet, a lot of seeds, vegetables, a cup of peanuts. My wife hates it that I eat my peanuts. I am noisy eating my peanuts at home. And I have to eat them at the porch. But a cup of vegetable, or olive oil in your salad, or whatever you want to dress it with your whole grain food, vegetable, fruits, and
Glass of red wine.
and a glass of any alcohol.
Any alcohol.
And that's right. So the dietary patterns that came out as being protective in the dietary guidelines are exactly what you two are describing. It's diets that are high in fruits and vegetables, it's in whole grains, it's in nuts and legumes and seeds, low-fat dairy came out there. And while, lean meats were a part of it, the fact is that most Americans consume twice the amount of protein of what they actually need, okay? And so basically the mind switch is that instead of using like nuts and seeds on top of your salad, we should be sprinkling protein foods on top of our plates so that they're just minimized as opposed to having 1/3 or a half of our plates full of protein. And so that's the kind of mindset switch that the dietary guidelines is really trying to promote to help not only cardiovascular disease, but also different types of cancers, as well as trying to mitigate the obesity epidemic that we actually have.
I just wanted to throw out really quick that an excellent resource for the Mediterranean diet that's also very kind of patient or consumer friendly. Has anybody been to Old Ways? The website Old Ways? I don't know if it's a .org or a .com, but if you put in Old Ways Mediterranean diet, It's, and I don't give out a lot of outside of UVA patient education, non-vetted websites very freely, American Heart Association, but Old Ways is excellent if you or anybody, any of your patients are interested in kind of starting to adopt that.
Gabriella?
Hi, I'm Gabriella. I'm from the School of Nursing. I'm in my third year of the Doctorate of Nursing Practice program. Dr. Reeds, I was really curious about the last slide, and I know we kind of flew by it, but what really stuck out to me was, I believe there was information about, I think I wrote it down here, that the majority of respondents said that provider conversation only made a small change in their diet. And it was a little discouraging to me as a future FNP that our conversations are actually not making a big change in their diet. So that tells me that either our conversations aren't really making a big difference, or we're not doing conversations the right way. I would love to hear your input, because you know that data really well, and what would be some possible alternative solutions. And if what I'm hypothesizing is correct, what do you think?
So I'm gonna let Vicki start, and then I'll end up with my answer.
Well, I think the most important thing is to work with the patient and make changes that they can make. I mean, we can give them all this information, but you know, if we just give them information, it's going in one ear and out the other. They're gonna take the paper home, it's gonna lay on the counter. Nothing's gonna happen. Because you have to help them see how they can make maybe at least initially small changes in their diet to reach some of these, you know, to eat better and more healthy. But, you know, if you just say, oh, you've got to do this, you know, you've got to do this, this, and this, and you don't work with them to see how they can incorporate it into what they're eating, because if it's not something, you know, even if they agree to do it, if it's not something that they're really incorporating into what they're already doing, then the chances are they're not going to do it for very long. So, you know, helping them to see how, you know, talking to them about what they do eat and helping them make good substitutes for some of the things. You know, there are some things you can make substitutes for that they go, oh yeah, I can do that. But if you just give them, you know, just a diet, they're not going to follow it. I mean, well, the study shows most of the time they're not going to follow it. They're not going to take it. But help them to see how they can incorporate those principles into their food.
I wanted to add something to that, because one of the things I study is behavior change. And the one component you don't have the luxury for is time. So if you would see them once a week for 2 months, chances are your advice would be taken and there would be some change coming out of them. But just that one piece of information in a very short time, and like you were saying, giving a stack of papers, that's not going to do it. You also need to consider what kind of change is required. So I go through this all the time in my classes, because in kinesiology we talk about exercise or activity and diet. Now, imagine this. You have a person who says, I want to exercise 30 more minutes every day. And you have a person who says, I want to cut out any kind of food, it doesn't really matter what it is, every day. So in order to make the dietary change, they have to be good all day long, to be able to, at the end of the day, check this off and say, yes, today I didn't eat X, or I did eat more of Y. Whereas for the 30 minutes physical activity, they might be able to split it up and do 3 times 10 minutes, or 1 time 30 minutes, and they're done. They can check it off. So some changes are easy, or easier. Other changes just require a lot of constant effort, and I think that's something that in the very time-limited setting is not adequately addressed.
So I'm gonna let Paul make the comment, but based on our scientific understanding, and both Vicki and Sybil have actually touched on this, interventions that are successful require high intensity, high frequency, okay, and constant follow-up. And they also, an individual has to be ready to make that change. So understanding an individual's stages of change in terms of, are they just contemplating? Are they ready? They are totally in denial. Well, you've got to understand where that person is coming from and to be able to work with them. And it takes time. time, frequency, you know, you need to know what you're talking about, and they need to be able to feel comfortable asking you repeatedly for information and follow-up. Paul, did you want to say something?
Yeah, just one quick point though, in terms of what you all are up against. Think about something that Max referred to, and that is the context within which people are making these food choices. It's not just a question of information provision. It's not just a question of what messages you're able to convey in the clinical setting or in your office, and it's not a question of their willpower or intentions. Think about the environment, right? Think about the small fraction of food-related messages that any of us get during the day that have anything to do with what we're talking about, right? Most of what we are encountering has to do with, like, go to Bennigan's and have more Pepsi, right? Those are the messages that we encounter everywhere. And so the overall food environment is one that is not hospitable to making the sorts of, you know, life adjustments and decisions that we're talking about here. But the other thing is, not just in terms of the messages, but what's available, right? I mean, I was talking to Dana on the bus who were saying, you know, in this country right now, you just go like this and you come back with a bag of chips in your hand, right? They're everywhere, right? Without even trying. We are bombarded not just with food messages, but with food that is pushing us against the kind of healthy outcomes that we're talking about here. And so that's not something that they're going to willpower their way through, and it's not something that you're going to persuade them through, but it is something that we all have to grapple with and reckon with, right? That's the larger context. And I think it raises the bar and it makes your job much more difficult.
We like to say in the nutrition field that if we could just make healthy eating the default option, we would all be in a much better place. I saw a couple of other hands up. That had a question. Yes, ma'am.
Well, just like an exact follow-up to that, what would you recommend for helping to make nutrition the default option? Because I feel like it, obviously our counseling needs to be part of that, but I do feel like there's a lot more that needs to be part of it. I wonder what ideas or what things, yeah.
Do you guys want to take a stab at some of that?
Well, I think the partnership that we're seeing here tonight is a good start, right? If there was more of that, where you become aware of local, reliable, trustworthy sources, where somebody might actually say, we're out of this because that's the natural progression of having a harvest and having food that's locally grown at the time when it's right, rather than shipped from heaven knows where. So in changing the environment to offer more opportunities to be closer to the source and to establish a relationship with the people who grow your food so you can trust them. So I think that's part of it. But you're right, it's a huge ship, and to turn it will take a while, but it's going to be one little step at a time.
Any other inputs?
Some of the ways to get to the default option is to regulate taxing sugary products. Banning trans fatty acids. Just the ban of trans fatty acids that it was officially federally applied this year is going to prevent, I think, like 35,000 deaths the first year. So but people don't like that institutional, that demand, like it's happening in New York City, that people don't like that they cannot drink a super cola. But it's one way, particularly to make people that have limited resources spend their money wisely, and now they used to buy a product that was high in sugar, now it's 20% more costly. It doesn't sound very democratic that you're taxing the people that don't have access to have limited resources, but it's one way to make it sort of a default way, is to limit the availability of bad food. Other challenge that I was going to mention, what I was going to mention is the repetitiveness in the message, and if we dedicate time on planning how we're going to do a procedure on you in the cardiology office and take 20 minutes and then 2 minutes, and by the way, here's your brochure on healthy diet, we're starting the wrong direction. What I try to do is, there's a wonderful strategy that was put together by Northwestern, and is the ABCD in lifestyle modification, which is A is assess a perception, and you ask them on a scale of 1 to 10, how important do you think exercise is in your lifestyle, and assess motivation. Then B, based on the motivation, what are your barriers to achieve those changes that we're starting to talk about? C is, let's commit to those goals. In 2 weeks, why don't you cut back to one teaspoon of sugar instead of 3 in your coffee? And then D is deliver results long term in regards of what you want to do a year later. So systematic approach, repetitive, again and again and again, more time rather than devote. And our institutions love to have people in the cath lab. I stop people from going to the cath lab every day, and it's because we should be caring for the patient.
So the other thing I wanted to say in response to that, and both of you have touched on certain parts of it, is that if we really want to change our environment, we need to think about the social ecological model that actually has the individual at the middle of that model, right? And then we live within our families, which is called the interpersonal, then comes the community, then comes institutions, and then comes the social environment policy aspects. In order for us to be able to live healthier lives, we actually need to penetrate every single level of that social ecological model to be able to make sure that our environment is supportive of healthy foods, a built environment that is supportive of physical activity. And so you just heard some of the policy recommendations that could potentially be made, but there's also institutional changes. We could actually demand that the food that's served in the cafeterias, both in schools as well as in hospitals, actually reflect exactly what we had here, okay? So that's part of making the foods that where we eat, play, work, and live are actually more of the healthy default kinds of foods. I think we're gonna take one more question, and then I wanna be able to send you all home because we need to go home and get our sleep.
Yeah, I just want to comment on the temptation in making changes. I've worked in hospitals for many years. One of the things that makes me crazy is the vending machines. If you step off the elevator, it's full of junk food. That's my mission, is to find out who I can contact to get that changed. So I'm working on that. But the cafeteria is another bad place in the hospitals. They've got pizza, fries, burgers that are put on a grill, a greasy grill. I do want to say, on behalf of the cardiology department, I have a few friends that work in that area, and I'm happy to hear that they are doing more nutritional teaching, cooking classes, and that's what makes it hard for a lot of patients. I've gone from vegetarian to vegan. It's a transition, even for somebody who understands it, but learning how to buy the foods and cook the foods and have them on hand took a good 6 months, so it's not easy. But anyway, I'm not trying to promote what I do, but to make a change, it does take work and education. But I think visual aids, whether it's, documentary, whatever, to help patients understand it, are helpful. But the cooking classes that are being done at UVA, in fact, I'm trying to get my patients into those classes, and hopefully they'll grow quickly and we can get that going. But that's another thing, is nurses and physicians is working towards developing classes for patients that are not, that are affordable. That's the other issue.
Any other last burning question from our audience? No? So I want to thank the Virginia Farm Bureau. Oh, wait a minute, Norman and Molly, is someone going to say something? I just got a message. Yes? No?
Molly, you want to say something?
No, go ahead. Oh, okay. I guess not. I want to thank the Virginia Farm Bureau and all of our local farmers who came out to be a part of this conversation, to our panelists, to the Morven Farms. We very much thank you for allowing us to be here and to host us, and to UVA Healthcare Dining and the chefs. Really, this has just been a wonderful event, and I hope you'll spread the word. We do want to have more of these types of activities, and feel free to email Paul and I with suggestions of how we can do a better job. You will be getting a post-survey.
Yeah.
And so thank you once again for coming out here. Did you want to say something? Yeah. Good.
I wanted to make sure that on behalf of the wonderful the dining healthcare dining services who put on the dinner tonight, you get a honey to take home. You also have the fruit out front, and there's some pens and brochures from Farm Bureau. And I just wanted to take a moment and thank again our panelists for taking the time to be with us, and for the farmers who came out and spent the day with this afternoon with us, Jamie and Stephanie and Kevin and Jim. So thank you all. Please travel safely back into town. And we do hope to be following up with you with future events, and be sure to give us your responses back in your surveys. Thank you.